Everyone. Welcome back. So let's move on to the second session of the plenary on prevention and care. Our first speaker is Renata Sanders. She's an associate professor at the Division of General Pediatrics and Adolescent Medicine at Johns Hopkins School of Medicine, and is currently the medical director of Pediatric and Adolescent HIV/AIDS program. Her primary care of interest is the prevention of HIV acquisition among adolescents, with particular focus on HIV testing, PrEP, and expansion of clinical services for sexual and gender minority youth of color, including adolescent transgender women and men. Her talk today will be on ending the epidemic through prevention in priority youth populations. Thank you.
Thank you. So thank you to my inviters for inviting me to come to give this presentation. I hope to give you a little bit of an idea of what we do around adolescent medicine and adolescent health, and why I hope to convince you that this population, this key population of youth, is as important and critical for you all to focus on as well here in Thailand. I want to start with a video. Can you turn
come
up the
across a rough path to come this far. I aim to see Bangladesh to a level where women and men both can go to college. There is no child marriage. We want to be heard.
So this young lady, this is a series of videos that are available where adolescents, young adults are advocating in their own communities. And this particular woman is from Bangladesh, and she is advocating for women's rights and women's access to education and to prevention around child marriage. And so I hope today, through this talk, we can also find areas where we can each advocate for the youth that we care for and the populations that we hope to address. For this talk, I'll provide you with an overview of key populations of youth here in the Asia-Pacific region, as well as describe some contributing factors to HIV in this population, and then outline some approaches to youth surveying clinicians and what I hope we can all do to expand care in this population to help mitigate risks for youth. We'll start with some background. In 2018, 1.6 million people worldwide became newly infected with HIV. It's estimated that over 500,000 were among youth that were 15 to 24 years old, and this is our generation. This is our future. And this is a high number, so over 1 million individuals that were youth became HIV infected. In the Asia-Pacific area, what we see is that rates of HIV are pretty high among certain populations. Particularly, let me point out a couple of countries. In Thailand, it's estimated that 47% of new infections occur in this age range, and as much as 69% in the Philippines. So this is quite staggering. So who are the key populations that we should focus on, and who are the key populations that we hope to address when we're thinking about HIV? I think it's focusing on the young, gay, bisexual youth who is cisgender, male, is one particular population. Young men who have sex with men, cisgender men who have sex with other men, carry some of the highest burdens of HIV in this area. Followed by female sex workers and male sex workers, as well as transgender youth that are disproportionately impacted by HIV. But we cannot forget about the youth who also inject drugs, as these are 3 and 4 key populations that are disproportionately impacted by HIV. I want to start first by giving you a framework of who youth are. The UNAID, as well as the WHO, have defined youth differently by age categories, and this will help us to frame what our focus is. So children have been defined as individuals who are less than 18 years old, whereas adolescents have been defined as individuals that are 10 to 19 years old, youth 15 to 24 years old, And for the purpose of this talk, I'm going to focus on young people, which includes youth, 10 to 24 years old. I'll focus on the younger population, particularly because I want to highlight some developmental features that are important and critical as you start to address youth. So starting with factors that contribute to HIV. Bronfenbrennan's framework is a socio-ecological framework that is a very effective way of addressing HIV among youth because you can actually think about it from multiple levels, both at the personal level, the social level, structural level, which are actions or rules, systems that are in place, and then also at the policy and larger cultural level. By using this framework, we can actually place the adolescent into different discrete boxes that will not only identify key areas of focus, but also potential interventions that we can each address. So starting with the youth, there are 3 areas that I want to focus on today. First, development, sexual risk, as well as uptake of prevention behaviors. These are only 3 of many areas that impact the youth on the individual level. But some of these areas are some of the highest areas that youth experience disparities. So starting with the developmental stages. Adolescence is divided into 3 key developmental stages. There's the early adolescent, which is the period from 10 to 13 years old. This is when puberty is starting. So there are the physical changes of puberty, breast development, change in penile size, for example. But this is also when gender identity formation may occur. And when there's a conflict between one's assigned sex at birth and their pubertal developmental changes, that's when individuals may experience what's called gender dysphoria because they realize that their body actually doesn't match. This is also when adolescents start to have a really hard time understanding things abstractly. So they're much more concrete during this period, meaning A plus B equals C. So if you're counseling an adolescent and you tell an adolescent, if you don't use a condom every time you have sex, you will get HIV. But if they use a condom intermittently or occasionally, and you don't tell them that they've acquired HIV, then your theory of A plus B must not equal C. It must equal D. So why use condoms? It negates the approach that you've used, right? So really thinking about how to frame things in a more abstract manner or in a concrete manner, depending on the age of the adolescent, will be very critical. It's also important to think about the personal fable that happens at this age. And that's really the uniqueness of adolescence. I think adolescents are wonderful. If you recall in your own adolescence, when you were a teenager and you walked into a room, you assumed everybody was looking at you, and nobody was looking at you, right? But that's what an adolescent thinks. An adolescent thinks that I'm unique, I'm special, and I'm different. And how does that relate? Well, that relates to I won't get HIV. I'm invincible. I'm not at risk. In middle adolescence, this is when individuals really start to think about their future. But there's also this disconnect between the brain and the emotional reward center. So the reward center is actually elucidated. It's actually alerted. So instead of making appropriate decisions that actually may reinforce the frontal area, it actually reinforces the reward center. And during late adolescence is really when individuals start to come back around, think more about their parents, and actually think more about their family values and their long-term goals. So looking at these 3 stages again in more detail. So this first stage of adolescence is really when individuals start to question their puberty and gender identity. They start to compare themselves to others. Am I normal? Do I look right? Why does he have that and I don't? Or why does she have that and I don't? So they start to compare themselves to others. They also start to experience a lot of anxieties about their own physical appearances. And because of that, they may try things that may or may not resonate with who they are. because they're really trying to try things out to see what works, what feels right. During middle adolescence is when sexual identity formation really starts to develop. Individuals start to test out their sexual relationships, their sexual attractions, and so this is when youth might start to verbalize being attracted to someone of the same gender or same sex, and so they start to question whether or not they're gay or bi or straight, or really coming into knowing one's sexuality. And during late adolescence is really when they focus more on the long-term, mature relationships, really thinking about the future, but also thinking about maybe having a child in the future, maybe thinking about what life means, having those strong bonds. And so using this framework, you can really start to think about how, as you think about interventions, what's most appropriate depending on the development of the adolescent. From a risk perspective, I think it's really important to think about three particular areas. I'm going to focus on sexual onset, sex work, and older partners and condom use. So early sexual debut, younger than 16 years old, has been associated with greater HIV risk. And several studies have demonstrated that sexual onset actually varies depending on the population of focus. So meaning if you are a sex worker versus a transgender woman versus young men who have sex with men, individuals that have are in different key populations are likely to experience different age of sexual onset. For example, in Afghanistan, 61% of young men who have sex with men described that their sexual debut was before 15 years old. Whereas in Pakistan, a lot of the transgender women had sex during their 16 years age range. So you see that there's some differences. In some countries, early sexual debut is as young as 14. Why is this a problem? Well, this is a problem because younger age at first sex actually creates a dynamic of risk because of the sexual risk that exists. So both the female cervix as well as the anal mucosal is not mature, so it has immature epithelium. And so during that time, if you're exposing someone earlier, or if someone is exposing themselves earlier to bacteria in a potentially vulnerable period as well as a vulnerable biological system, they're going to be more likely to acquire HIV or sexually transmitted infections because they just don't have the mature epithelium to protect them against that sexual infection. Also, adolescents, when they start earlier and their partners may be older or even same age, they may not have the maturity to negotiate condoms. So we talked about the developmental stages. They just may not be able to negotiate condom use quite well, particularly if they're the receptive partner, right? So the bottom or the vaginal receptive partner. And then their partners may be more likely to have HIV. From a sex work perspective, there is evidence to suggest that women and men who actually engage in sexual work actually start at an early age. And so it's estimated in the UNICEF report that 40% of female sex workers actually started selling sex before the age of 18. Often these youth are displaced from their homes, either due to economic situations or due to sexual orientation or sexual identity, and they're forced into an environment where they're forced to engage in sex work. And sex work actually carries the risk of being exposed to older partners that may actually have higher rates of HIV as well. This quote really embodies some of the work that we've looked at around older partners. And so this cisgender male talks about meeting his partner who was over 5 years was actually 7 years older, and that partner actually exposed him to a lot of different environments. He started to go to clubs, he started to go in different environments, and so what you see is that older partners carry risk because of greater risk for HIV acquisition because they're in a higher HIV prevalent community or network, but they also carry a greater risk because they potentially may expose younger adolescents to risky environments and risky situations. I want to move to condom use. Condoms are physical barriers, actually, that have been demonstrated to prevent against HIV and other sexually transmitted infections. I mean, the good news is that they are actually up to 97% effective if they're used correctly and consistently, so all the time. The challenge is that youth often don't use them correctly or consistently. I hear often from youth saying that they start to have sex and then they realize and then they put a condom on, and I always tell them once you put your hand on that doorknob, you're exposed. So once you touch that doorknob, you touch the door, you're exposed. You have to have a glove on the hand, even from the beginning, right? And so condom use is really important to really highlight and to discuss with youth. There's been a couple of studies that have looked at lack of condom use in HIV acquisition, particularly in one study, in Bangkok of young men who have sex with men that were 18 to 21 found that HIV incidence was as high as 8.8 compared to 5.9 in the other population with individuals that did not use condoms. And particularly, there were high rates of condom inconsistent use, particularly among all populations, but I want to highlight that it was greatest among young men who have sex with men as well as transgender women. There are multiple reasons for non-use, and so it's really important to unpack that when you're speaking to your youth. What we found in the U.S. is that there's really lack of knowledge around condom use, as well as lack of planning. So a lot of youth don't have condoms with them, so we have a big old condom closet so that when they leave us, they can actually go and get a variety of condoms that work for them. And the reason why we have a huge selection of condoms is because not every condom is right for everyone, right? So some condoms have ribs on them to enhance sexual pleasure. So pleasure actually has been one area that has been described as a reason for non-use. So decrease in sensation during sex, youth are less likely to use condoms. So let's move to low HIV and sexual health knowledge. Low HIV knowledge and low knowledge of how HIV and sexually transmitted infections are acquired, it results in low HIV testing as well as low engagement in sexual preventive behaviors. And so the WHO and UNAIDS has really established that individuals should be providing comprehensive sexual education that includes counseling around increasing condom use, voluntary testing, and decreasing in unintended pregnancies through the use of condoms. And so these key recommendations were released in 2015, and what I want to just demonstrate to you all and talk about is that still there's variation that exists, and there's variation across the board around who receives comprehensive sexual education. An estimate suggests that only 13 of 28 countries in this area actually have policies that are in place for comprehensive sexual education. And it's estimated that less than 50% of schools and youth actually receive it in these countries. So really low amounts of sexual education. So if youth don't know, they won't use and they won't know to go and get tested. Looking at uptake around PrEP, there are two forms available for pre-exposure prophylaxis. You've heard a lot about pre-exposure prophylaxis already in this meeting, so I won't go into too much detail in this section, but there are two forms available. One, and I want to highlight the second form that recently became FDA approved in the United States because of some particular barriers around adolescence. and that is the tenofovir. The lower one here, that is the Descovy, and the TAF emtricitabine, FTC. So PrEP has been available and approved for a long time, and in 2018, it was approved based on weight by the Food and Drug Administration. So regardless of age, if anyone weighed 35 kilograms and older, it was approved for use in that population. These are the regulatory, this is the map of the regulatory status of TDF FTC in 2019, and what you see is that there's lots of variation that exists. The green are the countries that actually have generic and approved for prevention, so highlighted here, as well as in Thailand. The darker colors are countries that have Truvada specifically approved for prevention, and then there are some other countries that actually have generic forms, and in this country, as you know, that there's both Truvada and generic tenofovir emtricitabine. But let's look at PrEP initiations by country, and what you see is that PrEP initiations have really been geographically distributed in only a few countries, right? So South Africa, the United States has some of the highest proportion of users around the world. And then you see Thailand here, and as you heard earlier yesterday, there are over 11,000 users here in Thailand. And in adolescents, there have been some really key programs that have tried to expand pre-exposure prophylaxis use in adolescents, particularly in the Rainbow Sky Association clinics and the adolescent clinic as well. But there's still a whole lot more to do in this area. And there are not that many youth that are actually on PrEP, and the adolescent clinic data that was released suggests about 150 to 200 users in that population. So going back to the socio-ecological framework, we're going to start to look at some interventions that will hopefully help you as you're engaging youth and trying to address HIV in this population. I want to start with the interpersonal or the personal level right here, and really thinking about knowledge as well as beliefs. Self-efficacy is also really important, so it's really important for youth that's the concept of youth really feeling like they have the ability to do a certain action, right? So it's not enough just to provide condoms, but it's also important to really sit down with youth to really understand whether or not they have the experience or they feel like they have the tools necessary to actually use condoms effectively. So it's really important to think about your programs from a youth perspective, and so we call these youth-centered developed programs. And when you're thinking about a youth, it's really important to think about not just the youth, but also the context that they're in. Youth are also often in the context of, as we described, their age or development. That includes their ethnic and gender identity and sexual orientation, but also their family environment, whether or not they're receiving adequate support in their setting. Experiences of stigma and minority stress. Minority stress is particularly important for sexual and gender minority youth. There's substance use and mental health, which often intersect with both of those. Lack of housing and lack of employment. So all of these can actually impact one's ability to use condoms and to engage in preventive behavior. And so not just focusing on the adolescents is important, but also focusing on the larger environment and what they hope to become, right? So really understanding where they are in their development, their timing of coming out, what's going on in their life, but also understanding their desires for relationships and intimacies. I have a teenager and I don't want them to be in a relationship, let me tell you, but it's a normal part of adolescence. It's a normal part of growth and development for them to have intimate relationships. And so you want to be able to incorporate all that into your counseling. I do want to talk a little bit about comprehensive sexual education. and what resources are available. And with a little bit of time, I'll have to stop this, but I want to show you the Advocates for Youth have resources that are available that you can access online and use anywhere, and really different topics that can actually be very helpful to youth. They've been developed from a youth perspective with youth input and adolescent expertise input. And so this particular video focuses around, am I ready to have sex?
I know it's perfect timing. My parents are going to be out of town. We'll have the whole house to ourselves. It'll be only me and Ethan. Andy said he'll bring candles to set the mood. I'm just not sure that I'm ready to watch the new season of Game of Swords.
Is it Game of Swords or is it something else?
Being sexually intimate, that is, having any kind of sex with another person, is a very special and unique experience, and feels best when it's between two people who care deeply about one another. Deciding if and when someone is ready to have sex is a tricky question.
So what you
Others may
see is
have an
that they use a
opinion,
combination
but only
of
the two
cartoons,
people
but they
involved
also
can
use
truly answer
developmentally
the question.
appropriate language.
And there is a lot to think about when trying to decide. For
They use
example,
partners that are
how
from
do you feel about the other
both
person you're thinking of having
cisgender
sex
and
with?
opposite
How do
gender
they
partners,
feel about you?
trans
Is
partners.
the other person kind to you? Do they treat you with respect? Do they want good things for you? How do you think you'll feel afterwards? Will you feel awkward, or will you feel closer and more caring towards one another? Once two people think they might be ready to have sex, there is still more to discuss. It's important to talk together about each person's sexual history. If either has had
They
sex
use
before,
visual
it's a good
cues,
idea to get tested
including
for STDs
condoms
and HIV before
and
having sex together.
information.
It's also important to talk about and get protection. Will you use condoms, birth control, or both? Where will you get them from, and when? Have you talked with each other about what you're willing and not willing to do sexually? Can you agree on and respect each other's limits? Can you agree to stop midway if either person becomes uncomfortable? Sex can bring people a lot of pleasure, but it can also bring concern and worry. Unprotected sex can lead to worry about pregnancy or STDs. Misunderstandings about what having sex means to the other person can lead to awkwardness and hurt feelings. In many places, there are also laws about who can have sex with whom, especially if one person is underage. And remember, just because you have had sex with someone once does not mean that you have agreed to have sex with them again. And just because you have had sex with one person does not automatically mean that you're going to have sex with another. It's your choice to say yes or no each and every time. So the answer to, am I ready?
So we'll stop there, but will you see multiple good experiences and allows you to talk to the adolescent in a general framework instead of, some of those areas were taboo, right? But they were funny, right? So it uses comedy and it uses culture to really try to approach different views and different areas that may actually be a little sticky and a little uncomfortable for youth. Let's see if I can go forward. Oh, I gotta stop this, sorry.
Comfortable with your decision.
Let's see. I might just have to scroll for it. Give me 1 minute. And this video is about 3 minutes long. Let's see. Here we go. Okay, so going back to our framework, it's really important to also think about the adolescent in their context, right? So adolescents are not alone. They're often with parents, families, and really it's not that we want to cut parents off and do a parentectomy, but we really want to engage parents and to really help them to have the skills to be able to talk to their youth, because youth want to hear from their parents. It's important when you're speaking to adolescents in the context, in their environment, in your clinic, that you really create inclusive space that is welcoming to all individuals, regardless of sexual orientation or gender identity. And this is a visual representation that we have at every check-in center. So something that says everyone is welcome here, that has all the colors, right? And that has words that welcome everybody. Social media also has the potential to engage youth. And there's been some good work that's been done in different areas, particularly this was done in, I believe, in Vietnam. And so this is actually an Ask Marlo app where youth can go on, ask questions about their health, around HIV testing, and actually get individuals to, if they have questions, if they want to come into the clinic to get tested or to receive counseling, make it accessible. And then COPE, YMSM, is a study that's been done by Chris Bauer and his group that has used social media influencers and SMS texting to actually engage youth. So that's another strategy. So using someone who is actually in the community that's visible, that's seen as someone who is cool or hip, to actually engage around HIV testing to encourage youth into testing is really critical as well. So just going back to our framework, it's really important to think about some of the institutional policies and practices as well. You've already heard about the Princess program, so I won't speak too long about this, but I just wanted to highlight one thing, that over 1/3 of individuals in this population were youth, and youth had experienced the greatest challenges with adherence. So if you're going to actually prescribe PrEP and you want to engage someone around prevention, you really need to provide a lot of adherence support for this population. We have a youth-based peer-led model where we have a youth coach that is slightly older than the population that we're reaching. We're targeting 15 to 24 years old, and so here's one of our coaches. He's from the community. We try to get people from the community. They're trained in motivational messaging and motivational interviewing, so they provide motivational support for the youth. And then they text with the youth to actually discuss with them how they can reach their goals around prevention and health. And what you see here is that this youth says, because they let me know that I'm not alone, there's always somebody there I can talk to. It's also important to have community messages that are inclusive and sex positive. So this is a sex positive campaign that's out of Chicago. And it really incorporates different individuals, different types of couples. And what you see is that there are messages that are positive, reframing sex as positive and reframing intimacy as positive with different types of partners. So transmit love instead of HIV. And here's one that is actually based on an ad around Adam's Love. You may have seen it, but really just embracing men being who they are, men being men, and knowing their status, and really engaging individuals into testing. So really having expanded messaging as well. There's also an opportunity to expand forms of PrEP. So I mentioned this medication earlier. So in Descovy, tenofovir alafenamide replaces tenofovir disoproxil fumarate, or TDF. And so why this is important, in the non-inferiority study, it found that it actually was associated with fewer HIV infections during the follow-up period, but also it's a smaller pill size. And so what I find is that youth are actually able to take this medication a lot easier than they are to take the tenofovir emtricitabine because of the larger pill size. So it's almost like 3/4 the size, slimmer and thinner as well. I'm over time, but just to highlight one thing is that in the ADAPT study, this study recently came out this month, actually looking at qualitatively how young men describe using on-demand versus time-driven versus event-driven, daily versus time-driven versus event-driven PrEP. And what they found is that a lot of the young men described that it was easier to use the daily PrEP than the time-driven and the event-driven PrEP. And that was qualitatively. So they did qualitative interviews when they followed up, and they really found that the event and time was very hard for the younger populations. So theoretically, I think a non-daily approach is really what we need, but a lot of adolescents and young people don't have the ability to plan using that approach. So I think there's more work to be done in this area. I'm gonna skip that. But just really quickly, there are structurally policies, laws, and regulations that are needed to be in place for youth to be able to access HIV testing and confidential services. And then school policies are really critical as well. So really school policies that actually help to support youth to make sure that they are supported, as well as criminalization laws. So really thinking about those laws. And particularly, I think one thing to highlight is that same-sex marriage policies in the US actually have been associated with decreased rates of suicide in adolescents. And so there are structural changes that can happen. I know that homosexuality is not illegal in Thailand, for example, but as it's not illegal in the US, the expansion of same-sex marriage laws in the US has actually had lots of impact on the health of youth. So thinking about what are the larger structural policies that may actually impact youth from a broader perspective are really critical, as well as thinking about how we expand access for care for male and female sex workers, a population that's particularly vulnerable and may not be included in enumerated studies and surveys, right, because of the age of the adolescent. And so thinking about how we can reach those really key populations that are not accessible so that we can actually do a better job in identifying them and reaching them more systematically. I'll end here. This is really a talk that really centers around focusing on adolescents and key populations. But I think that the larger question is how do we make sure that health is equitable and accessible to all populations? And I think that by expanding services for youth in a very youth-centered, friendly perspective, we can just do that. Thank you.